Good afternoon, everyone. My name is Sarah Barker, representing my company, Connect Our Elders. And today I have Dr. Diane Darby Beach, a gerontologist with Family Matters in-home care, as my guest. So thank you for being here today, Dr. Diane Darby Beach.
Of course.
I'm going to call you doctor from now on. Just
okay.
Straight doctor. So before we get started with some questions that really revolve around the pandemic and how it affected families and clients and the various types of care providers, could you share a little bit about Family Matters in-home care, what sort of services they provide?
Absolutely. So we're a non-medical in-home care agency. We provide companion care. We provide cares for what we call activities of daily living, bathing, grooming, eating, meal prep. All of our caregivers are dementia trained, so we're really well suited to help those folks that have dementia or any kind of cognitive impairment as well.
I think that that's really a huge differentiator for you guys because, and maybe you can share with the audience. So, licensed home care companies, which in the state of California, you must be licensed. And so there is a certain level of required training, but I mean, how intensive really is that training? And then, are other home care companies taking the extra step to ensure that their caregivers are dementia trained? I think that you guys, I think you guys might be the first one that I know of that makes sure that all of them are.
Right. And, a lot of them may say that they do some measure of training, but most likely that's via webinars, and because that's the most efficient way to provide training. But Family Matters takes that extra step, which is great, and provides the actual live training, dementia training. Of course, it's been on Zoom as of late, but we will return to live training as we come out of the pandemic. And it is important because the majority of clients that any home care agency will see, they're going to have some kind of cognitive impairment, and our caregivers need to be trained. They need to be trained, and when they have those tools, they do a better job. The client's more satisfied, the family's happier. It's just a win-win.
I couldn't agree more. You're setting them up for success, right? And so a better delivery of service to the client as well.
Right, because if you send somebody out into a home and they don't have the tools, and dementia's tough. I mean, and some of the behaviors that go along with dementia are tough, but if you've got the right tools and you know how to handle the behaviors, it's not such a mountain. It's more, you can break it down and you know that you can do it. And if you're confident and you can do it, then you exude that also to the client. They can sense whether or not the caregiver feels good about what they're doing.
Oh, absolutely. Absolutely. So, could you also share, I know when I made the announcement, I put in there some about your background, but could you share right now with the audience who you are and the things that you have done in the past that makes you so specialized in this area?
Oh, thank you. Yes, I've been a gerontologist for almost 30 years. My specialization is dementia care. I'm not an MD. I'm not a prescriber. I have a doctorate in education and a master's in public health. I got interested in this years ago when I was working in exercise science and started noticing that a lot of people that were in our groups were caregivers for somebody at home. And wouldn't you know, at the end of our study or our program, the caregivers that stayed in the exercise programs did much better than those that didn't. And they did better on their depression scores. They did better on their stress scores, their burden, their anxiety, and their physical parameters, their blood pressure, their high cholesterol, their diabetes, etc. So, I really got interested in this. I knew for some reason that this dementia thing was going to be huge. I had no idea how huge. I was a very young professional then, in my 20s. So now we're sitting here at the crux of what I call the volcano or tsunami of healthcare. But if you look at like a volcano, we're right here and it's about ready to take off because people are living longer and age is the biggest risk factor for this disease.
Yes. So back to you being a gerontologist, right? And then you became, really specialized, hyper-focused on dementia. What made you decide to be a gerontologist all those years ago? Because I know in current time, right, like everybody's focused on the elder population and, it's an industry that is growing exponentially. But 30 years ago, what made you decide to go that path?
So 30 years ago, I was looking at exercise with older adults, spending a lot of time with them. I've always been an old soul. I was, spent a lot of time with my grandparents growing up, more than most. And I was always around older adults and loved them and always felt like they had a lot of wisdom. So doing the grant study, coupled with the fact that my grandmother, who was very instrumental in my upbringing, had Parkinson's disease and had Parkinson's related dementia that goes at the end of that disease. And I watched a woman who was so vibrant. She did Jack LaLanne every day. Some of us remember Jack LaLanne, others of you don't. You're too young. She did Jack LaLanne. She rode her bike. She swam. I mean, women didn't sweat back then. And I watched that woman go from that to being slumped over in a wheelchair, slobbering, hair disheveled, probably hadn't been washed in days, and it was devastating to me. And that kind of catapulted me into the fact that, you know what, no one going forward under my watch will be treated like that. Nobody.
I admire your why. I find that everybody, if you've been so focused in this area, you typically have a big personal why behind it. So thank you for sharing that. Mm-hmm. All right. So moving to our line of questioning. Okay. Coming out of the pandemic, how have the needs of caregiving families, clients, and residents changed?
Well, I mean, and all of us, if any of you are professionals listening to this, we're all really busy right now, because what had happened during the pandemic, not surprisingly, is families sat on these decisions. They may have been ready, right? Mom needs to go to assisted living. Mom needs memory care. Dad needs some in-home care assistance. The COVID pandemic pretty much shut everything down. And understandably so. If I'm a family member and I'm thinking I've got to place my loved one, I may not see them for months. So now I've traumatized them by making them move anyway, right? Because it is a trauma.
Yes.
And then they can't see me. So they sat on that. Or they didn't want to have home care because they were afraid of bringing the virus into the home. So what's changed dramatically is people are coming to us now with a stress level that's exponentially higher than normal. And so as professionals, we're having to really adapt to that and know that their baseline is their stress, their anxiety, their depression. It's a lot higher.
That's a good insight. You're the first person I've heard mention that, and it makes a lot of sense, because it's been sitting there, and now it's kind of reached this boiling point, right? How do you think? Because I think we all know, all of us in the industry understand the caregiver shortage, right? And it's across the nation. When I'm here in Tennessee, or if I'm in California, or talking to people in other states, everybody is struggling with that. So. How is that playing out with these families who have finally reached the point where they're saying, okay, things have kind of lifted with COVID. Now we're ready to get help. And then there's a lot of agencies that are saying, okay, we can help, but maybe we don't have a caregiver today or tomorrow or for a week.
Well, exactly. And, the whole unemployment thing has created a mess with that. And, understandably so, caregivers are not making a ton of money. This isn't like a real money maker. A lot of them are making as much or more money sitting on unemployment than they are coming to work. So that's been a big obstacle for us. I think the positive of that is, and what I'm seeing is more collaboration amongst professionals. So instead of, home care A is competing with home care B, therefore we'll never refer to each other. Now we're saying, okay, I've got this client in need. She's in the college area. We don't have caregivers down there. Can you staff it? I'm going to call another agency, and I've always had that approach. I want to be a team player, but in the business, there's a lot of competition, especially in home care. So now we need to collaborate. We need to cooperate. We need to be a team, because the overall objective is to get these families help. And I don't care who helps them, really. I mean, I'd rather Family Matters help them if it's home care, but if we can't help them, then I want somebody to help them.
Preach it. So this is exactly my philosophy too. And it has been really nice to see in the industry, companies that typically, they are competitors, but would never consider, sharing or collaborating, are now doing it out of necessity because of what you just said. Our obligation, all of us at the end of the day, is to get the client help, the family help. And I've seen situations where, one of my clients actually, right, home care company, company A could only cover these shifts. Well, you know what? the client needs the other shifts covered too. So there were two companies in on that client.
Exactly. I mean, I was in on a intake just yesterday, and there was some confusion, and there were two home care companies, and I said, okay, they had already contacted the other people. I said, as long as you have care, I'm good. So that is it at the end of the day. And as a gerontologist, any of us in the industry, yes, we recognize that it's a business. Yes, we all need to pay our bills. However, the eye on the prize is that client and that family, and however we can help them, that's our obligation, period.
Yes. Yes. Okay. So how has hospice care been affected by the pandemic?
Well, hospice care is facing some of the similar issues that home care is, and as well as, skilled nursing and assisted living. However, I think what I'm seeing with hospice is that this has created an opportunity for us to further delineate for our clients and for the community between palliative care and hospice care. And there's been so much misunderstanding about that. And this has provided us more of an opportunity to really educate people on that and on their advanced care directives. A lot of these people are kind of coming up out of the pandemic and realizing, I don't have an advanced directive. I don't have a DNR. I don't even have my post filled out. So these are opportunities for us as professionals to make sure that people get those documents in order.
I agree. Would you mind explaining real quick for the audience the differences between, what is palliative care and hospice care?
So I don't work for a hospice. So any of you out there in hospice, excuse me if I don't delineate this exactly the way you would, but this is how I see it. And I think this is pretty true. Hospice care is end of life care. It is 6 years, the physician has diagnosed you and said you've got 6 months or less to live. Now, when dementia, we can't really do that, so we operate on a different set of criteria, which has to do with their activities of daily living and failure to thrive. Hospice care is when the family, the person has, according to their DNR, their advanced care directive, has said no more treatment. All right, so if I'm cancer, I'm not getting radiation anymore. I'm not doing chemo anymore. I'm getting comfort care. My pain is being managed. My spiritual needs are being managed. My family is getting some stress reduction. All right, that kind of thing. Palliative care, on the other hand, is also comfort care, but you can still be getting treatment. So I may still be having chemo or radiation, and I'm getting palliative care, which means I'm getting my pain managed. I'm having some lifestyle aspects of my life managed. I'm having some spiritual care. My family's getting some of that care. Really, the key difference for me is that hospice is truly end-of-life care. No more treatment. We're not treating anything aggressively. Palliative care is comfort care, pain care, symptom care, and I'm still getting treatment. I'm still pursuing my treatment plan.
Thank you for so effectively clarifying that. I mean, that was an excellent response for those listening to be able to understand the difference. Okay, have in-home care and assisted living been impacted by the COVID crisis? And if so, how?
Yeah, and exactly the same thing I mentioned before. People are coming to us with much higher stress levels. So I'm coming into a community to tour my family or to tour for my loved one, and my stress is different. My decision-making capabilities may not be the same. I'm more in crisis mode. I've been sitting on this for a year. I'm tired. I may not be as picky or selective. Same with home care. People are coming to us and they need help, but they may not get the care that they really want, but something is better than nothing. So as professionals, we kind of have to step into that advocacy place, because even though they are not able to maybe make those decisions more clearly, now it's our job. Now it's my job to say, hey, you know what? I know you didn't notice this about the activities, but let me just point out that this is really what should be going on. So they may not be seeing things as clearly. So we need to really be their eyes and ears more now than ever.
I like that. Advocating and helping to reduce the overwhelm. I'm not sure, your experiences, but I have a feeling it's similar. I find sometimes so a lot of people want to give 2 or 3 options when it comes to resources to help the situation. And I see the benefits in that also. But a lot of times I will give just one resource because the families are already so overwhelmed. They are really reaching out to you as an advisor. And I like to say that those of us in the elder care industry, you are no less of an advisor than their attorney, right? Or their financial planner. Like, you just have a different thing that you're advising on. And so that family is really looking to you, to Dr. Diane Darby Beach, to tell them what the right decision is, you know, versus saying, well, here's what I think, and then you still have to decide, right?
Well, and so with that position of more power comes a really clear and needed understanding of ethics in our practice. Because again, it's a business. Now I can go, you know, and throw business at one person versus another, but that's not my job. My job is to ethically do what's right for the client, for the resident, for the patient, and their family. And that takes a lot of skill, and what it takes is real honesty, is, you know, flat bread honesty.
Absolutely. All right. How has mental health among seniors and their families been affected by the lockdown?
Well, the biggest thing that I'm seeing is the effect of social isolation, not only on the client or the resident, but the family. Now, we see this in general anyway. As people age, let's say somebody's diagnosed with dementia, by that, the very nature of their diagnosis, their world gets smaller and smaller and smaller, right? They can do less, they want to do less. Now, the family caregiver gets pulled along in that, and their world gets smaller and smaller, which puts them all at risk for depression. What happens with social isolation is that people do get depressed. They go hand in hand. All right, we're meant to interact with other human beings. When we get depressed, our self-esteem plummets. Now we're in this downward cycle, right? Self-esteem goes down, I get more depressed. The more depressed I get, the less I want to be social. Then my self-esteem drops further, and it goes on and on and on and on and on. So that's happened. People are already coming to us pretty far progressed in that trajectory as compared to before COVID. We have been isolated, and the research is substantial and lengthy on the negative effects of social isolation on our mental health. So that's what's happening. That's what's been happening to all of us, frankly. But
how do we recover? I mean, it's easy for us, right? We can start going out again, interacting with people, meeting, going to restaurants, you know, doing those activities. How do we help our elder population recover from the increased isolation over the last, 365 plus days?
Well, I think for seniors in the community dwelling seniors, we need to slowly, like if you're a family member, don't expect to go right back to the activity level that person had prior to COVID, right? Because now they're not used to it. They want it, they need it, but they're not used to it. So it's a slow reintroduction to activities, maybe at the senior center or some of the activities that a caregiver did with them. They're allowed to get out and go to the park now, but just don't want to do it all at once. Okay. And you also need to reassess where this person's at, not just cognitively, but physically. Have they deteriorated more, which most likely they have. So now they're not using a walker, but they need a chair. So that's going to mean getting out and doing activities is going to look different. So I think A, we just don't assume that they're at the same level that they were prior to COVID, and B, we slowly increment activities back in. For people in the residential care facilities, they're especially new residents, it's all new to them anyway. But again, it's just, still, COVID or not, it's all person-centered care. You do an accurate assessment of the client, the resident, the patient before you're trying to introduce activities or have them come into a facility, and know where they're at and adjust to that, because not everybody's at the same place. I mean, they're not. You may have several people at the same places, but not every single person's at the same place, and they can't be treated as such. We have to treat them individually. as much as
meet
possible.
the person where they are, right? Where they are on their journey. I'm curious to Family Matters in-home care. What is your process for when you receive a referral and you go do the assessment? Are they looking at sort of, what types of activities would stimulate the client and then implementing that into the plan of care?
Yeah, and again, that's part of what we train everybody on is this person-centered care planning. So it's not just gathering information about a potential client's medical history. I mean, we need to know that. What's their diagnosis? What's their primary diagnosis? What were they hospitalized for? If so, and if they were, what happened? What's the history of that? What is their cognitive level? That's all super important. However, and I train the caregivers on this all the time, what's equally important is what's this person's social emotional history? What did Alice do for a living? What were her routines? What are her hobbies? What brings her joy? What makes her sad? What people does she love? Which people in the family annoy her? I mean, these are all things to know. Not that we can change those things, but we can certainly help the client adapt when they're happening. So if I do a care plan and I ask, okay, what about Bill's routine? What time does he get up and have breakfast in the morning? Well, he never gets up before 8 o'clock. And when he gets up, he likes to have his coffee, but he doesn't like his breakfast until 11 o'clock. Okay. If I didn't know that, and I sent a caregiver out there and the caregiver comes on shift and says, hey, Bill, let's get ready. It's the morning. Let's have coffee. We're going to have breakfast. You've lost him at, hey, Bill. He's way back there. And, so one thing at a time, and then, okay, we're going to have coffee because that's what he does every morning and reads his paper. And then he hangs out. And around 11 o'clock, we're going to do breakfast. So that's just an example of person-centered care planning.
That's really refreshing because it is one centered on the person and how they're existing, right? That their patterns, their structure that they already have, but also you guys are taking it a step further than just saying, okay, are they warm, rested, and fed, right? It's like what matters to this person and how can we add to their quality of life?
Well, exactly. And again, and I train the caregivers on this, that, it's really important for you to have this information about their social emotional history, because even when you're doing something like helping with an activity of daily living, right? Maybe you're preparing a meal. There's no reason why you can't be talking to Alice about, so I know your favorite food is this. Who cooked that for you the first time, Alice? Why did you like lasagna so much? Let that person talk about their experiences. But if you don't have that information as a cue, then you can't do it. But we're not there. We tell the caregivers this all the time. We're not there just to do their activities of daily living. Yes, that's our primary reason. But also, we're there to provide a meaningful experience for that person. And that can be as simple as a conversation.
You just gave me goosebumps. I mean, that's what they're craving the most. And I know you've experienced this, right? Like I have contact with the client, I get them set up with the resources, right? And then oftentimes they call just because they're wanting to talk, right? And so if the caregiver's already in the home, ensuring the safety and the ADLs, having that conversation is so meaningful to them.
Well, and it's like we tell the caregivers, especially with COVID, but even prior to that, sometimes the caregivers, that's that client's only human contact during the week, right? Or one of the few. So they are looking to that caregiver to kind of be the bridge to the outside world. And that's a big responsibility. So that has to do with being able to come in and, like you said, join their journey, know where the person's at, be able to make a connection with them. And in the case of dementia, we talk about this a lot. Just because they're non-communicative or their communication is erratic or maybe even illogical, that doesn't mean they can't communicate. And that doesn't mean we can't communicate with them, because so much of our communication has nothing to do with what we say, with what comes out of our mouth. As a matter of fact, 75% of communication is nonverbal. It has nothing to do with what you say. It's your facial expressions. It's whether or not you're engaging the resident or client in eye contact. It's your body language. It's the energy you give off. If you've just had a big fight, with your husband or wife, and you're a caregiver and you need to go and be with this client, you better have a way of kind of clearing yourself of that energy before you go in, because otherwise the client's going to pick up on it really fast. And if they've got dementia, they're like sponges nonverbally, because they've had to rely more on their nonverbal communication. It's like if you or I, Sarah, were to lose our vision. What happens to our other senses?
They get heightened.
Essentially, I have to rely more on my hearing, a sense of smell, taste, tactile. All right, same thing with somebody with dementia. When they're losing their verbal communication skills, their nonverbal gets really good, really good. So if you walk in and you've got some energy going on because something's happened in your personal life, that person, I tell my caregivers about this all the time, you're going to have a bad shift. I'm just going to tell you.
I was going to say, they're going to absorb that energy and then just push it right back on you. I would imagine, before we move on to the last question, I would imagine the fact that you guys are providing such substantial training to the caregivers that they feel invested in, right? And so, a sense of loyalty to Family Matters in Home Care. They, it makes them feel more of the professional that they really are, and they're valued.
Exactly. And, it's like any of us. If you have the right tools for your job or for your life, whatever it is, you're going to have more confidence. You're going to be better at what you do. The person you're serving is going to pick up on your confidence. It's all going to be a win-win. And so our caregivers do, and they tell us this all the time. Thank you for the training. I mean, and as you know, most caregivers, they work for multiple agencies, or they've got experience in multiple different environments. And I've had many, many caregivers at Family Matters in Home Care say to me, in all my years of working and being a caregiver, I've never had this kind of training. Thank you. And thank you to the company. And we pay them to do the training. And that's wonderful. That's the way it should be.
So probably a silly question, but I'm going to ask it anyway so the audience can hear the answer. Are you guys hiring caregivers?
Absolutely. So give us a call. You've got the information there. I know you do. And contact us directly. We are always looking for people who want to do this kind of work. You are important people.
Okay, so all right, last question having to do with dementia and the pandemic. Have people with dementia and their caregiving families been touched by the pandemic differently than others? And if so,
yeah, I do. And I think people with dementia face a different set of circumstances, as do their family caregivers. So there may have been, what I'm seeing is more isolation, because people with dementia are more isolated to begin with. And so that's been exacerbated. The family has had fewer resources to help. Even in the collaborative family caregiving situations, which are ideal, those have been limited because of the participation and interaction that's been limited. So again, like the other populations, but even more so, our folks with dementia and their caregiving families are coming to us with a heightened level of stress, understanding, and need to have their care and their issues taken off their plate a little bit. I've seen the family caregivers, and in most cases, the family caregivers end up being my secondary patient anyway, and they have the stress and anxiety and burden and all that, but even more so now. So I'm seeing that I'm referring out for families more support and resources than I normally would.
Okay. How can when should people reach out to you? Can you give some triggering verbiage, or if they're overhearing a conversation somewhere, a conversation with their neighbor, or, for any of the, attorneys or financial planners that are listening right now, when should they say, you know what, I need to talk to Dr. Diane Darby Beach right now?
So things like, what if bills aren't being paid? Do they need a fiduciary? Do they need some help that way? I can help with that. If you're noticing, has the client had a recent medical situation that's precipitated maybe more help? Maybe they've had a fall and they've ended up in the hospital. They didn't break anything, but that's certainly a big red flag that let's get ahead of this rather than chase it. Are they having other depression and anxiety kinds of symptomology that you haven't seen before? Maybe you've got a neighbor or a client who seems pretty, had his ups and down days, but pretty good, and now doesn't want to get out of bed. Now barely answers the door when you come to visit. Those kinds of things. Do you notice, if you're a caregiver or a family member, any new bruises, any new physical indicators that would tell you maybe this person needs more help?
Okay.
Like unpaid bills, lots of expired food. That's a big thing. You go in there and you've got stuff in there from 2016, right? And you're wondering, is this person eating? I mean, really? Or are they hoarding? Any of these
Are they bathing?
Are they bathing? Do they look clean? Do they smell clean? Do they have clean clothes on? All of these things you want to pay attention to. And the biggest thing I would say globally with all this is, let's get ahead of it rather than chase it. If there are some red flags, then call me. And if I can't help you, I can certainly point you in the right direction. I have all kinds of resources. Family Matters has all kinds of resources at our fingertips. We just want you to get help. Period.
Right. And there is no harm in just having a conversation, right? So I would encourage anybody in the audience right now listening, if you have a family member, neighbor, all of the different ways that you touch people and come in contact with people, right? Just if you identify one of the red flags that she was just speaking of, just encourage the person that there is no harm in just having a conversation, getting some education, being prepared, being proactive. I highly suggest that versus waiting for a crisis to happen.
And thank you for saying that, because when people wait for a crisis moment, and they come, 9 times out of 10, they come, now you're scrambling. And if you don't have a roadmap, and that's what I tell people, no harm in a conversation. Let's identify 3 home care agencies that you might want to use. Let's go tour a couple of assisted living communities. Then you've got some possibilities. So when the crisis comes, you're not starting from ground zero.
Exactly. What territory does Family Matters in Home Care cover?
We're all over San Diego. And
okay.
And again, if we can't help you for whatever reason, if it's staffing or something like that, we will get you some help. But we cover all of San Diego.
Okay. And then how can people contact you, and where can they go to get more information?
So they can contact us at our general number, which is 760-970-8305. That's our San Diego San Marcos office. And then they will kind of ferret out whatever you need, whether you need to be in contact with me, they'll give you my contact information. If you need something else, they will help you with that.
Okay, wonderful. Well, I really appreciate you being a guest today. And as a reminder to everybody, Connect Our Elders is basically an overall resource. The entire intention of Connect Our Elders is to empower the aging process through educating the community on all of the resources that can assist our elders, and then helping them navigate those resources so they can figure out exactly what they need, what's appropriate to their situation, and then ensuring that they have the ongoing advocacy for an empowered life all the way to the end. So thank you so much, Dr. Diane Darby Beach, and I hope to talk to you soon.
Thank you so much. Thank you, everybody. Okay.